Hello, I'm Dr. Petra Steinbuchel, and I'm going to be talking about ACEs, trauma, and mental health assessment in pediatric primary care and outlining a stepped care approach. Here are the objectives for today's talk. And just by way of introduction, I'm a child and adolescent psychiatrist, and I've worked with children across all SES with many different types of trauma, screening, educating, and addressing the impact of adverse childhood experiences. And doing so with a trauma-informed approach is really close to my heart. Over the past 15 years, I've had the honor of working in collaborative relationships with many, many talented and dedicated pediatricians in the greater Bay Area in various integrated and co-located care models. I've learned that care and outcomes are best when we collectively consider the whole person, mind and body, and their greater context, including their household, community, and beyond. My hope is that through collaboration and consultation and mutual learning, we can together work towards a more integrated approach to mental and physical health care. My hope is that through this multifaceted training from an interprofessional team of ACEs and trauma-informed systems care champions, you will feel more comfortable, skilled, and knowledgeable at screening for and addressing ACEs in primary care, and that you'll be more familiar with a continuum of care that includes consultative models beyond the traditional model of referring out to specialty mental health. Throughout the talk, I will be referencing a couple of patient presentations that are a composite of many patients I've known over the years, and I am not referring to any specific individual, so any resemblance is incidental. We heard from Dr. Long that some of these definitions I'd like to share in order to help us be specific, not only about concepts, but also about how we're thinking about assessment and impact of ACEs, and also developing appropriate intervention approaches. So ACEs, when capitalized, refers to 10 specific categories of adversity in 3 specific domains: abuse, household challenges, and neglect, that are experienced by the age of 18 years. This was initially studied and published in 1998, the Center for Disease Control and Kaiser Permanente collaboration study with the same name. In California, the prevalence of ACEs score of 1 is about 2 and 3, or 62.3%. And an ACE score of 4 or more is 1 in 6, or 16.3% for adults. There are several risk factors for toxic stress. These can be a circumstance, an exposure, or a condition with documented associations of an increased likelihood or susceptibility of developing toxic stress response. In addition to ACEs, other risk factors for toxic stress include poverty and predisposing biological susceptibility, often considered in the mental and behavioral health domains. But scientific advances in the understanding of the impact of stress on neurodevelopment, in particular neuroendocrine, immunological, metabolic, and genetic regulatory health, compel an advancement of the definition of resilience to also include these domains. At the molecular level, resilience arises from a combination of neural, hormonal, immune, metabolic, epigenetic, and genetic factors that interact with environmental influences and foster an individual's ability to adapt in a healthy manner. Other stressors can include exposure to discrimination and exposure to the atrocities of war. Toxic stress is a prolonged activation of the stress response system that can disrupt the development of brain architecture and other organ systems, and increase the risk for stress-related disease and other cognitive impairment well into the adult years. For children, the result is the disruption of the development of brain architecture and other organ systems, and an increase in lifelong risk for physical and mental health disorders. ACEs are causally linked to toxic stress. Trauma is defined, individual trauma is defined as a result of an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. The prevalence of trauma is high, and the impact is thought to be widespread. We will talk about some of the common symptoms in response to trauma in just a bit, but many times these symptoms are limited and time limited and don't require further intervention. A small proportion of individuals who do experience trauma or a series of traumas that are either direct or indirect, for example, a police officer repeatedly hearing child abuse stories, may develop an acute stress response or post-traumatic stress disorder in response to this vicarious traumatization. The difference between acute stress and post-traumatic stress disorder is just the duration of symptoms. Specifically, that acute stress disorder occurs between 3 days and 1 month after exposure to the event, and PTSD is symptoms that occur or persist for 1 month after the event. If it lasts for 6 months or longer, it's considered to be chronic. Acute stress and PTSD can cause impairment in functioning with symptoms in several domains. The first symptom cluster is intrusion. Intrusive thoughts, such as repeated involuntary memories, distressing dreams, or flashbacks of the traumatic event. Flashbacks may be so vivid that people feel they are reliving the traumatic experience or seeing it before their eyes. Avoidance is another symptom cluster. It's normal to avoid reminders of the traumatic event, but this may lead to avoiding people, places, activities, objects, and situations that may trigger distressing memories. People may try to avoid remembering or thinking about the traumatic event. They may resist talking about it or how they feel about it. Another cluster is alterations in mood and cognitions. There may be an inability to remember important aspects of the traumatic event, negative thoughts and feelings leading to ongoing distorted beliefs about oneself or others. For example, I'm bad, no one can be trusted. Distorted thoughts about the cause or consequences of the event, leading to wrongly blaming oneself or someone else. Maybe ongoing fear, horror, anger, guilt, or shame. There may be much less interest in activities that are usually fun for an individual, feeling detached or estranged from others, and also symptoms of irritability and maybe having angry outbursts or behaving recklessly or in a self-destructive way, being overly watchful of one's surroundings in a suspicious way, being easily startled or having problems concentrating or sleeping. People with PTSD have intense, disturbing thoughts and feelings related to their experience that last long after the traumatic event has ended. They may relive the event through flashbacks or nightmares. They may feel sadness, fear, or anger. They may feel detached or estranged from other people. People with PTSD may avoid situations or persons that remind them of the traumatic event. They may have strong negative reactions to something as ordinary as a loud noise or an accidental touch. The prevalence of PTSD is about 4 to 8%, which is much lower than the prevalence of ACEs or trauma. Fortunately, we're also now starting to see some revisions to the qualifying criteria for specialty mental health. Historically, it's always been that you need to have a qualifying psychiatric diagnosis, but now, due to the recognition that we don't have to wait until pathology develops, and also recognizing the significant impact that trauma can have, we are starting to see some qualification based on the level of impairment in functioning. That said, mental health clinicians' focus of treatment may often be on the symptoms of acute stress and PTSD and/or other significant impairment in modifiable risk factors like toxic stress, in particular the attachment between the child and the caregiver, which offers substantial buffering to toxic stress. Before we dive in, I want to invite us to zoom out for a moment and consider that every child, every family is influenced by their greater context, which has many layers, including living conditions, the safety of their neighborhoods, and the equality and quality of their systems like schools, healthcare, and their broader society. This is a lovely illustration of the contextual factors impacting ACEs and resilience, as we like to consider not only the child, but also the household, community, and broader systemic and environmental contexts. The transactional model of development, which was first proposed by Samaroff and Chandler in 1975, offers a a consideration of developmental outcomes, including psychopathology, as a function of ongoing transactions between the individual and the environment, which exert continual effects the one upon the other. Similarly, relational developmental systems theory considers individuals as active and self-regulating, dynamically changing in response to and with the environment. These frameworks emphasize the continuous dynamic that a child has within the social context, which is considered essential for understanding developmental outcomes. For resilient families, we need healthy organizations, healthy systems, and healthy communities. The frontier of resilience research lies in creating communities and systems that prevent childhood adversity, stop traumatizing already traumatized people, including addressing minority stressors like discrimination and inequality in order to build resilience. Many people, organizations, and communities are already integrating trauma-informed care, trauma-informed resilience building practices based on ACEs science, including pediatricians, schools, juvenile detention facilities, businesses, social services, people in faith-based community health, health clinics, and the like. Zooming in a little bit more to the individual child and caregiver or family, as we heard in Dr. Long's talk, adverse childhood experiences are risk factors for the development of the toxic stress response or cumulative repeated exposure to adversity that leads to disruption in neuroendocrine, immune, and genetic development and regulation, which in turn increase risk for both physical, emotional, and behavioral health problems. The toxic stress response is defined by the National Academy of Science, Engineering, and Medicine's 2019 consensus report as the, quote, prolonged activation of the stress response systems that can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment well into the adult years. For children, the result is the disruption of the development of brain architecture and other organ systems and an increase in lifelong risk for physical and mental health disorders. This is a result of prolonged, frequent activation, not only of our sympathetic nervous system's fight-flight response that happens in the face of short-term stressors, but also activation of a number of secondary effects that toxic stress can have, especially in the absence of mediating protective factors like safe, stable, loving, and nurturing relationships at critical windows in a child's development. The impact is also determined by the duration and the number of adversities, the type, and also the age and developmental level of the child and the caregiver. In the neuroendocrine system, there can be dysregulation of the sympatho-adrenomedullary and hypothalamic pituitary adrenal axes, with long-term changes in regulation of key hormones, including cortisol and adrenaline. There may be autonomic imbalance as a result, and altered reactivity and size of the amygdala, inhibition of the prefrontal cortex, hippocampal neurotoxicity involved in memory formation, ventral tegmental area and reward processing system dysregulation. In the immunologic inflammatory system, there can be increased inflammatory mediators and markers, especially of the TH2 response, inhibition of anti-inflammatory pathways, and gut microbiome dysbiosis. In the endocrine and metabolic system, there can be changes in growth hormone, thyroid hormone, pubertal hormonal axes. There may be changes to leptin, ghrelin, lipid, and glucose metabolism, and other metabolic pathways. Genetic and epigenetic changes include the possibility of telomere erosion, altered cell replication, and premature cell death, and sustained changes to the way that DNA is read and transcribed. This list of ACEs-associated health conditions, you'll notice, starts with more of the medical or physical symptoms. And then the second part, the lower half of the screen, is focused more on behavioral and mental health symptoms. And one of the things that we see is that oftentimes as providers, we make the association between ACEs and, for example, depression or anxiety, but it can be harder for us, or we may often not realize the association the literature or the evidence showing the association between ACEs and, for example, cardiovascular disease, asthma, or obesity. Just like we would expect primary care providers to not ignore the relationship between physical and mental health providers can play an important role in connecting the patient's mental health issues with ACEs, toxic stress, and any ACE-associated health condition that the patient is experiencing. I'll demonstrate this more as we discuss the cases later in the presentation. So let's consider a couple of children who are presenting to a pediatric primary care well child care visit to help illustrate the impact of ACEs, toxic stress, and the buffering impact of relationships. The first example is a 14-year-old obese female with a history of depression since menarche at age 9. And the second is an 8-year-old physically healthy male who's doing well in school and socially. During a well child check for this 14-year-old girl who's brought in by her mother, you find that she endorses trouble sleeping, trouble concentrating, feeling sad sometimes, and often feeling numb, but also worried that something bad will happen. Her weight has steadily increased since age 7. She now has a BMI of 27, borderline diabetes with a hemoglobin A1C of 6.1% and 6.3% within the past 6 months. Her PHQ-9 score is 14. She lives with her mother, father, aunt, uncle, and 2 brothers, 2 cousins. Her mother has often seemed really minimally emotionally and verbally engaged. She sometimes misses appointments, and you've wondered if the mother may be depressed. The de-identified ACE score is 1. On further history, you learn that she's been cutting herself on her arms and more recently on her upper thighs. You meet with her alone, and she shares that the cutting has been both to, quote, help with anger and sadness, and, quote, just to feel something. You ask if she's willing to share about her ACE. She slowly begins to disclose that her grandfather had sexually abused her between ages 6 and 9, and then stopped when she went through puberty. He died about a year ago. She had not really remembered so much until 6 months ago, when a boy at school started to make some advances toward her, and she would feel frozen and not know what to do. After that, she began to cut herself to deal with the shame, sadness, and anger. And shortly thereafter, quarantine started, and she said that she felt, quote, even more alone. She had never shared this with anyone before. An 8-year-old boy presents for a well child check. He had just been adopted by 2 women who are married after having spent 2 years in foster care. He is generally physically healthy with some mild symptoms of inattention in school and some defiance at home at times. His past medical history is significant for asthma, and he uses both a steroid and a rescue inhaler. His de-identified ACE score is 5. On further history, you learn that his biological parents were both amphetamine users, and his father was physically abusive towards his mother and his brother, but not towards him. His mother had gotten sober when she was pregnant with him and was sober for the first 3 years of his life. His maternal grandmother had also helped to take care of him while his mother worked. He remembers both his mother and grandmother as being loving and nurturing. He remembers his brother also looking out for him and taking the hits instead of him when his father would be high or intoxicated. He and his older brother went into foster care when he was 4.5 after his brother was found to be staying home and missing many weeks of school, presumably to take care of him. And his grandmother needed to go on dialysis and was no longer consistently available to care for him. His father had just gone to prison, and his mother had become a heavy substance user. There was often very little food in the house in the 6 months before they went into foster care. He reports that he has good relationships with his caregivers. He feels safe most of the time. He enjoys his new school, karate, and church support, and has only asthma as his current medical issue. His parents are working with a family therapist plus a parenting class. He sees the family therapist periodically on his own as well. When we think about ACEs screening, it's really important to focus on the how, less so than the what of the raw number of the score. We operate under the assumption that these are normal responses to abnormal circumstances. Training in trauma-informed care does not require much work or time, but it does require us to reframe our role as healers. It requires us as practitioners to tolerate some ambiguity or uncertainty, and also recognizing that this is a journey and not a one-step or one-time touch. Being trauma-informed means offering as much choice throughout the entire process, including things like, shall I start with this ear or this one? Would you prefer to sit or stand? Emphasizing voice and choice as underscored by Jen Leland and Dr. Joanne Jung. It's important to use body language in a way that communicates to the patient and his or her family, I believe in you and I care, and not turning your back or looking at the screen instead of the person. It's important to have a universal screening framework throughout the practice. This means that this is about normalizing screening for ACEs and education on toxic stress, and can be framed as we screen all of our patients for a history of trauma, which may contribute to current and lifelong health. It means collaboratively engaging with the family, removing any lingering shame or guilt associated with the childhood trauma. It means ensuring good communication throughout and following up in the moment and having transparency. For example, my main goals are ensuring your safety and your physical and emotional well-being. I want to work with you to achieve this, and this may take some time. And thinking about the 14-year-old girl, you've known the family for many years, and based on this trusted relationship, you state to the girl and her mother that you usually like to meet with teens alone and ask both of them if that's okay. You share that you really care about her and ask what is going well. She doesn't say anything. You share that you know she's always done well in school and that she's always been a good soccer player as of your last well-child check with her. You share that sometimes cutting can be a way to help with anger and with sadness, and sometimes just to feel something. You ask if she's willing to share about her ACE. She slowly begins to disclose that her grandfather had sexually abused her between ages 6 and 9, and then stopped when she went through puberty. He died about a year ago. She hadn't really remembered it so much. And then when a boy at school was flirting with her, then she recognized that she would feel frozen and not know what to do. She started to cut to deal with the shame, sadness, and anger. And shortly after this, quarantine started and she felt even more alone. She feels so ashamed. And in this moment, what can you do? You thank her for her honesty in sharing this and tell her that you want to partner with her in helping her to get through this and to feel better. It's important to really consider that the message of silence, whether that is intentional or, not necessarily following up with a de-identified score, the message of silence can be really damaging to a trauma survivor, and it may have impacts on the provider and patient relationship. Silence can include in following up, not asking questions about receiving information around screening results. It may imply that the provider thinks the story is unimportant, or that the survivor is not safe in disclosing their story if they feel uncertain about what's going to happen next. It's far better to be upfront if you're not in a good space. For example, just to say, this is a really important story, and I want to spend some time talking through this with you. Would you be willing to schedule a follow-up appointment so we can have more time to talk about this? Disclosures can be really hard. Making sure that you really thank the person for their honesty. This really validates the importance of their story and their willingness to be vulnerable. It's important to consider a strengths-based approach, which, according to Bessel-van-der-Kolk, can be important in many ways, including allowing the person to, responding to the form or interview, to feel more known in ways than just the negative life events and the corresponding problems. It can give a fuller picture to staff so that the likelihood of armoring the hard shell that workers develop when faced with different client problems can seem insurmountable, and it can decrease if you think about strengths and the whole person approach. It also increases the likelihood that the strengths can be used during the service delivery process in follow-up. In research, it also provides a clearer and richer understanding of the relationship between the different variables that are being studied. For example, in the ACE study, not all individuals with higher ACE scores experienced the many health risks. Some didn't. It'd be helpful to know that if the reason for the difference is the protective factors in their early lives, how many protective factors or which ones diminish the effect of adverse experiences. It's important for us to consider the context and what are the contributing factors. So the biopsychosocial model was first conceptualized by George Engel in 1977 and looks at but beyond just the biomedical model, there can be a development of illness through a complex interaction of biological factors, for example, genetic, biochemical, as well as psychological factors like mood, personality, and behavior, and social factors like culture, family, socioeconomic level, medical illness that may influence things. And we now include the things like pandemics, natural disasters, determinants of health, and systemic racism. This is a really clear intersection between the nature and nurture debate, and it allows developmental psychologists a theoretical basis for the interplay of both hereditary and psychosocial risk factors. Other components that were added later include spiritual and cultural factors, and this is similar to the American Academy of Pediatrics biology, health and development, and ecology framework. Similar to this, we can consider what are called the 4 Ps in terms of thinking about formulation. What are some predisposing factors? For the 8-year-old boy, some predisposing factors include a biological history of mental illness and substance use, and possible in-utero exposure to substances, as well as his recent move. Possible precipitating factors, there aren't any really clear ones because he seems to be doing well, although he may be in a honeymoon period because he's just recently moved. Protective factors, we think about angels in the nursery who can be there. This is this modifiable risk factor that is really safe, nurturing, stable, loving relationships. He had really positive, secure attachment to his mother and grandmother at very critical moments in his early childhood. And also his brother really looked out for him and protected him. For the 14-year-old girl, we don't really know genetics for her as much in terms of predisposing risk factors, but we might wonder about mother's own history of trauma and possible depression, given her longer-term low engagement. And it seems that the precipitating event was her sexual development, and also this boy teasing and harassing her. Some perpetuating factors include her social isolation and relative lack of nurturing, loving, supportive relationships. Protective factors, we're not really sure about all of them, but we know that she's done well in school and other activities, and we want to know more about her peer relationships and other family relationships. We can't talk about trauma without talking about resilience. As discussed by Dr. Long, resilience is the ability to withstand or recover from stressors and results from a combination of intrinsic factors and extrinsic factors, like safe, stable, nurturing relationships with family members and others, as well as predisposing biological susceptibility. Of note, with scientific advances in the understanding of the impact of stress on the neuroendocrine, immune, and genetic regulatory health, we must advance our understanding of resilience and also having neuroendocrine, immune, and genetic regulatory domains. Stress mitigation strategies listed here have all been shown to reduce stress hormones, including reducing inflammation and enhancing neuroplasticity, key mechanisms to counteract the toxic stress response and to improve overall health and well-being. These strategies offer an integrative approach to ACEs and toxic stress intervention. They include healthy relationships, high quality, sufficient sleep, balanced nutrition, regular physical activity, mindfulness and meditation, access to nature, behavioral and mental health care. For further information on the science and benefits behind these, you can look at the Surgeon General's report under healthcare and tertiary intervention or prevention strategies. Applying this to the 8-year-old boy, despite his very high ACE score, he has had significant relational support at key points in his life. He was getting good sleep, reportedly balanced nutrition, and regular physical activity, along with access to nature and behavioral and mental health care. In contrast, for the 14-year-old girl, it's not really clear how healthy any of her relationships are, or whether she's getting balanced nutrition, sleep, exercise, etc. Thinking about trauma and impact across the lifespan, we want to think about how this might show up at different ages and developmental stages. Dr. Lieberman's talk will more fully address the impact of trauma on development, including the impact of toxic stress, which we define as repeated or prolonged activation of a child's stress response without the buffering protection of trusted, nurturing caregivers and safe, stable relationships that in turn lead to long-term changes in the structure and functioning of the developing brain, metabolic, immune, and neuroendocrine responses, and even the way DNA is read and transcribed. This is known as the toxic stress response. Shown here are some common symptoms that may occur in response to trauma, and these may be normal for a period of time. The key is that acute stress symptoms of re-experiencing avoidance or alterations in arousal or changes in mood may be normal and time limited, but if they last for more than 30 days, then this qualifies as PTSD. And if they last for more than 6 months, they are more likely to become chronic. Patients may also have symptoms of trauma-based nervous system dysregulation and not have PTSD. These symptoms, which are also common in PTSD, may include irritability, quickness to anger, anxiety, low mood, difficulty concentrating, numbing or having a lack of emotion, and feelings of shame and guilt. Trauma symptoms also include physical manifestations like headaches, nausea, shaking, chest tightness, shallow breathing, and lightheadedness, which is an activation of your sympathetic fight-flight stress response. These symptoms may also exist in caregivers who have experienced their own trauma histories and may present as irritable, impatient, apparently quick to anger, or maybe being more disengaged and shut down. The biological stress response has been characterized in 3 types: positive, tolerable, and toxic. In terms of positive stress response, not all stress is considered bad. Some stress is necessary and even essential as part of our growth and development. It can help us to transiently mobilize energy and increase focus to perform better on the task at hand, like an upcoming test, big game, or presentation at work. The positive stress response is characterized by brief elevations in stress hormones, heart rate, and blood pressure in response to a routine stressor. Tolerable stress response activates the body's alert systems to a greater degree as a result of more severe, longer-lasting difficulties, such as the loss of a loved one, a natural disaster, or a frightening injury. If the activation time is time limited and buffered by relationships with adults who help the child adapt, the brain and other organs recover from what might otherwise be damaging effects. Toxic stress response is defined by the National Academy of Sciences as prolonged activation of the stress response system that can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment well into the adult years. For children, the result is the disruption of the development of brain architecture and other organ systems, and an increase in lifelong risk for physical and mental health disorders. The upper Venn diagram here illustrates that there may be some overlap in symptoms of ADHD and traumatic stress response, in particular, difficulty concentrating, being easily distracted, disorganized, restless, hyperactive, difficulty sleeping. And it can be difficult to distinguish the differences, including difficulty with focus and sustained attention, poor frustration tolerance or irritability, impaired impulse control, and social ability. The lower circle, disinhibited social engagement disorder, can result from longer-term complex or compounded trauma, in particular the absence of supportive, nurturing relationships. We know that with inadequate or harmful input early on in a child's development, this can affect the developing brain and lead to indiscriminate social behavior, PTSD, ADHD-like symptoms, and/or conduct problems. Human infants are born with a really strong propensity to form attachments to a small number of caregiving adults with whom they interact regularly and substantially in the earliest years of their life. The failure of caregivers to provide co-regulation of children's emotional experiences has consequences for child development. These caregiver-child relationships are internalized by the child, and the quality of the relationship may impact other contexts. The children need consistent caregiving and loving, supportive relationships. So when you have a child who presents like the 14-year-old girl, what could be some possible next steps? This may be more than you can fully address even in one visit, and this may require several follow-up visits that have more of a behavioral health focus. For primary care providers who are motivated to conduct a follow-up behavioral health focus visit in the absence of any clear diagnosis, but with significantly impairing symptoms, you could consider some of the following screeners. For an initial psychosocial assessment, consider administering a general screening tool like the Pediatric Symptom Checklist 17 or the Strengths and Difficulties Questionnaire, which we'll cover next. The Peds Symptom Checklist 17 is a general mental health screening tool that's designed to be simple to use in primary care practice. It can help primary care providers assess the likelihood of finding any mental health disorder in their patient. The brief and easy to score tool has fairly good mental health screening characteristics compared with other instruments like the Child Behavior Checklist and what's considered the gold standard, which is the case-eds. Secondary screening tools and rating scales are designed to focus on a specific set of symptoms. For example, the PHQ-2 and 9 screen for depression. The SCARED screens for a number of different anxiety disorders and is validated ages 8 to 18. The GAD-7 screens for generalized anxiety disorder. The PTSD symptom checklist can be helpful in identifying the presence of PTSD. The Vanderbilt can be helpful in identifying ADHD and related conditions. And then for suicide risk, there are 2 suicide risk screeners that are available for use in primary care and designed really for outpatient primary care visits. One is the Columbia, and the website has a number of different helpful resources. And then the other is the Ask Suicide Screening Questions, ASQ, that helps assess patients in an outpatient basis. The Strengths and Difficulties Questionnaire can also be helpful in assessing commonly occurring pediatric mental health conditions. It is used as a research tool throughout the world in developmental, genetic, social, clinical, and educational studies. In community samples, multiple informant SDQs can predict the presence of a psychiatric disorder with really good specificity and moderate sensitivity. And it's available in a number of age ranges, ages 2 to 4, ages 5 to 10, ages 11 to 17. There's also a self-report for older children and also ages 18 and above. This graphic from the CDC really highlights what falls ideally into the PCP skill set and toolkit. The most common resources that are requested are parenting classes, parent support groups, and more information about trauma and its effects. This mirrors the AAP policy statement about what we should offer, including positive parenting and anticipatory guidance. Evidence-based interventions with primary care practice include trauma education and the goal is really to create safety, to build relationships with families, to understand, to educate in order to help heal, protect, prevent, and build resilience. Parents may also need mental health referrals. And so this is important to consider as you're conducting an assessment and psychoeducation. For children who have experienced trauma, if you can think outside the box about what might be helpful, including things like mentoring programs, big brother, big sister programs, clubs and activities that offer social connection. So this slide is adapted from Anne-Marie Mitchell, and it's really meant to help us think about a framework for assessing overall functioning and thinking about the severity and the impact of symptoms and what can be managed within primary care, and then when to enlist more consultation and or to consider referral. In terms of thinking about, the green, we draw this back to Dr. Long's slides around the note. Noticing strengths in relationships, offering science through anticipatory guidance and positive parenting. What are the tools in terms of trauma education, stress busters, education on relationships and development. And then E is for empowerment. In the yellow, may be managed in primary care, but may also need referrals out. We think about, what are the basic needs and what kind of community resources could address those? What types of specialists can we enlist, including medical subspecialists, as well as mental health specialists and substance use treatment. And then in terms of parenting, we think about the stress mitigation interventions. When we think about really needing to intervene is when there's an imminent safety concern, and thinking about enlisting community crisis, 911, and or consideration of a CPS report. When you do need to make a CPS report, this may already be part of your practice, but it's really important to be very transparent or to consider that in any case where that's possible to do. I always try very hard to make sure that the parent is still in the room when I'm making a CPS report so that they can hear exactly what I am sharing with the CPS worker. And that helps to go a long way to maintain the relationship with the family. When we think about enlisting referrals and resources, we think about what is the continuum of care and how severe is it? What are the needs? We think about different systems, the medical home, the community, school, regional center, specialty mental health, and then juvenile justice may be included in here, and or social services as well. We think about kind of levels of care from lesser interventions to higher levels of interventions. And we really want to think about what is necessary in the moment, what is practical, and what is possible. In this, really want to underscore the importance of interprofessional communication, collaboration, and relationship building throughout and across these different systems of care, as well as with the family. So now to our step model of care. This is a model of care that's more widely used in other countries, for example, in Europe, in the UK, and Australia. This diagram here is from the Ames Center at the University of Washington, which has really been at the frontier of behavioral health integration. And the Ames Center is most widely known for its work in spreading the collaborative care model. But many of the practices we work with incorporate collaborative care into a blended or step model that combines other behavioral health interventions and strategies. Blended models of care seen in successful integrated practices frequently combine collaborative care and the primary care behavioral health model, also known as the behavioral health consultant model. The idea here is that primary care providers are at the front line of treatment for many, many people, and that there are a limited number of specialty mental health care spots, and that there is a lot that can be managed within primary care with consultation and support from behavioral health specialists, including psychiatry and therapists. We also want to think about, what is the prevalence of commonly occurring mental health conditions. For example, the prevalence of depression in teens is about 10 to 18%. Presence of anxiety, the prevalence of anxiety is about 20 to 30%. Substance use disorders can range between 10 and 12%, and PTSD can be between 4 and 8%. Meanwhile, the prevalence of trauma exposure is upwards of 60%, as we've heard. We also want to think about what is the access to care for providers. We have about 100,000 psychologists in the United States, about 8,000 child and adolescent psychiatrists with an estimated need for about 40,000, and about 800 developmental pediatricians. We want to think about operating under the principle that we can provide effective, low-intensity treatments that are offered first, and that higher intensity treatments are offered to those who are at greater risk in terms of their acuity and complexity, or past treatment failures, or who don't improve with that initial treatment. And that we want to regularly review the progress on how things are going and ensuring that they're improving. This diagram illustrates a step care model as applied to the diagnosis of depression. But this step care approach has been applied to a number of different diagnoses, including PTSD. The key is the severity and complexity and the appropriate intensity of the intervention based on this. Step care really seeks to treat patients at the lowest appropriate level of intensity of care that's still going to provide some benefits, to monitor a patient's progress longitudinally, and to reserve more intensive treatments with specialists for those patients who don't benefit. The key is that a lot of people may go back and forth in terms of their severity levels, depending on the context and what is going on in terms of their current stressors. So if we can take a look at what could actually be managed within primary care and consider the patients that we met earlier, mild to moderate treatment-resistant sleep issues, asthma, attention problems might fall into step 2 here on this diagram. For step 3, it just depends on whether you have access to a more integrated team or consultation, as well as each individual's primary care provider's own knowledge, skills, and comfort in trying to address perhaps more severe symptoms of depression. Let's look at how the step care model works for our 2 patient cases. In terms of follow-up and treatment planning, we think about the framework of safeties. He has no active concerns for danger to self. His specific behaviors or symptoms include some mild inattention, possible concern for expressive language, difficulty, and some defiance, but he does respond to redirection. These behaviors occur in the setting of home and school. And we've described his past trauma, but none in the past 2.5 years. In terms of services in place, he has a CASA worker and he has a family therapist. And so in terms of this visit, this would be in the green category of providing counseling. That includes anticipatory guidance, education on how toxic stress can increase inflammation and affect asthma symptoms, given his high ACE score, and that the stress-busting tools, including addressing relational health, sleep, nutrition, activity, mindfulness, and access to nature, accessing community support like Big Brothers or Big Sisters program, and when needed, access to mental health care can help his overall health, including his asthma, his behaviors, his learning, and overall neurological, endocrine, and immune functioning. The primary care provider can consider addressing asthma symptoms, including education about use of inhalers, and consider support for his school, and consider a 504 or IP evaluation if his symptoms and school challenges worsen. For the 14-year-old girl, if we think about this framework of the 5 S's, we think about safety. She has been cutting, but she's not suicidal, but she does have some hopelessness. She doesn't have any plan for suicide and doesn't have any apparent concerns for danger to others. And there's no concern for current abuse. In terms of specific behaviors and symptoms, she seems to be pervasively depressed. She's cutting, She's binging in response to overwhelming emotions as a way to manage them. And these symptoms are happening across all of the different settings in which she finds herself. She has talked about these past traumas as described. It's not really clear if she's experiencing any current or recent bullying by peers, and she has no services in place. So when we think about what are the things to address in that continuum of care, through a safety suicide risk assessment through the Columbia, walking through this concern for suicidal ideation and any current risk for danger to self. But this is concerning. And so you consult with a child psychiatrist via phone, engaging the mother in safety planning, including what would be the criteria threshold for bringing her to the emergency room or calling 911. Trying to use motivational interviewing to engage the family to commit to therapy. And they actually agree to this. You also would want to refer to specialty mental health, given the severity of symptoms, with the goal of first establishing safety and then decreasing the self-injurious behaviors with a family therapy component, ideally, a mindfulness component, to consider medication, specifically an alpha agonist like clonidine or prazosin for the nightmares, and potentially an SSRI like fluoxetine for the long-term depressed mood and binge eating. And after establishing safety, then being able to delve into more trauma-focused components. In terms of her medical care, I'm going to follow up on the hemoglobin A1C and provide education around healthy eating and eating for strength, thinking about forming healthy habits that include not only healthy eating, but also sleep, exercise, time in nature, yoga, mindfulness, and healthy relationships. And consider substance use treatment, and of course, the stress mitigation strategies that we referenced earlier. You could consider making a CPS referral depending on the responses and if there is active concern for safety in the moment, as well as inquiring about the past abuse and needing to make a report on that. But again, ideally doing that with at least the mother in the room, and depending on how the child is presenting, to do it with her in the room as well. This can be incredibly validating for a child who's just disclosed this, and to be able to listen to and be a part of this sharing with CPS and understanding what the next steps are. These handouts from ACEs Connection can really help to explain and provide psychoeducation on the impact of ACEs and toxic stress on overall health and the tremendous importance of a caregiver-child relationship. Helping mitigate the stress response cycle through these interventions can help improve multiple health conditions, including asthma, anxiety, depression, and obesity. I wanted to highlight some really high quality psychotherapeutic interventions that are important to consider. Healthy Steps is a 0 to 3 program and is an evidence-based, team-based pediatric primary care program that promotes the health, well-being, and school readiness of babies and toddlers with an emphasis on families living in low-income communities. Child-parent psychotherapy for young children from birth to age 5 years and their parents and caregivers really helps to support family strengths and relationships, helps families heal and grow after stressful experiences, and respects family and cultural value. Triple P program, which includes or is positive parenting program, is a parenting and family support system that's designed to prevent as well as treat behavioral and emotional problems in children and teenagers. It aims to prevent problems in the family, school, and community before they arise, to create family environments that encourage children to realize their full potential. There is also, while the main program is ages 0 to 12, there is also a teen Triple P for parents of 12 to 16-year-olds. And there are also specialist programs, for example, children with a disability that can participate in stepping stones for parents going through separation or divorce, called family transitions, and other specialty services that include lifestyle interventions for children struggling with obesity and Indigenous parents. Parent-child interaction therapy is conducted through coaching sessions during which the parent and child are in a playroom while the therapist is in an observation room watching a parent interact with a child through a one-way mirror and or a live video feed. And the parent wears a bug in their ear through which the therapist provides in-the-moment coaching on skills that are being learned in order to manage a child's behavior. Recently, trauma-focused cognitive behavioral therapy was developed into a stepped care model called stepped care trauma-focused CBT, in which the first step is a parent-led treatment where the majority of the treatment is provided at home by the parent. The at-home treatment is supported with 3 in-office sessions with the therapist, phone support, web-based psychosocial information, and also video demonstrations. And there has been some substantial benefit with this model. Attachment, regulation, and competency treatment is aimed at treating more complex trauma and focuses on attachment, strengthening the caregiving system surrounding children through enhancing support, skills, and relational resources for the adult caregiver. The second piece is regulation, cultivating awareness and skill in identifying, understanding, tolerating, and managing internal experiences, and then building competency, including increased opportunity for choice and empowerment, and skill in recognizing choice points and an effective decision-making, as well as identifying and exploring a range of aspects about self and identity and building coherence through development of narrative around key life experiences, including trauma exposures. I also realized that I had skipped over dialectical behavioral therapy, which is really aimed at adolescents, although there is now also a younger child version of this for children aged 7 to 12 that is intended to establish safety and improve emotional dysregulation, distress tolerance, being able to walk the middle path, negotiating and navigating relationships, and enhancing interpersonal effectiveness for families and children through a combination of individual work, coaching, and family skills sessions. Wanted to say a word about pharmacological approaches, which are not the first-line interventions for PTSD in children, although they may at times be helpful in treating specific secondary symptoms like anxiety, nightmares, depression, again, depending on the duration and the level of impairment. So in summary, wanted to invite you to consider a stepped care framework that can guide intervention approaches based on symptom severity and current level of functioning and impairment, as not every child who experiences ACEs or trauma requires intervention by specialty mental health. We know that a strengths-based, trauma-informed approach deepens, enriches, and supports the context of assessing and addressing pediatric ACEs and toxic stress, as we know that the quality of relationships with us as healthcare providers and between caregivers and children has significant impact. Being able to see a child and a caregiver for all of who they are, including their strengths and not just their problems, allows for growth and healing, and also helps us as providers. Collaboration and consultation with mental health providers can also really help pediatric primary care providers expand their knowledge, skills, and confidence in assessing and addressing common mild to moderate mental health concerns in the spirit of whole child, whole family health. Thank you very much.